Our Prevent Child Abuse project really was spawned in 1999-2000. One thing that we had observed in some of our grant making was that in several of the larger communities across North Carolina and South Carolina, we were making, in some, when you add several grants together, in some we were making grants well over $1 million to some of these communities on an annual basis. The limitation, though, was that these grants were fragmented. They didn't have the scale or the scope to move the community needle, to see if we were actually having impact at the community level. So we created a white paper back in 1999, and we shopped it around with various authorities and experts across the two states and even across the country. And we created a hypothesis or a concept where we said, what if we were willing to make a long-term commitment to a community with sizable grant funds such that they could create an environment with comprehensive services that were well coordinated for a specific objective. And that objective in this case was a measurable reduction of child abuse and neglect. There were two different projects that we ultimately funded under this concept. One in Greenville, South Carolina, was led by Dr. Gary Melton at Clemson University. The other was in Durham, North Carolina, led by Dr. Ken Dodge at Duke University. The Greenville project took a less traditional approach. In Greenville, the theory of change hinged around not necessarily providing new services or formal services. Rather, it hinged around changing the culture in the environment such that neighbors were more willing to help neighbors. The theory being that if you had a neighbor, a village if you will, that was willing to support each other, then raising children was much easier, and your likelihood of affecting those children in a negative way was diminished accordingly. The approach in Durham was more traditional. What Dr. Dodge was trying to employ in Durham was a strategy of identifying high-risk families and then marshaling resources to those high-risk families. In addition to that strategy, he also developed a relationship with all the public providers in Durham to try to get them to work more cohesively together. That's known as a system of care model that they were trying to implement around prevention efforts. 6 years into the initiative, here's what the data are telling us. In Greenville, they had tremendous success in mobilizing the community, which was one of their primary strategies. They were able to document that numerous volunteers had coalesced around this idea of creating a safer environment for children in the Greenville community. They also, through some door-to-door surveys that we conducted, had documented evidence of improving parenting. So parents are more effective, which presumably ultimately would lead to safer children. The struggle we had with the data that came from Greenville, however, was that their primary medium for change was that neighbors would be more willing to help neighbors, that there would be a cultural change, if you will, within the community such that it was a more helpful community to support children and families. The data that we had based on the door-to-door survey did not bear that out. So while we had mobilization of the communities and while we had improved parenting, we don't think we got to it through what they had projected to be the medium of change, and that was an environmental change or a cultural change around how families are supported. In Durham, the data so far are more encouraging. For instance, over the first 7 years, there's been a 73% drop in child abuse and neglect substantiations for children ages 0 to 17. When you compare that with the 5 comparison counties, there was only a 25% drop in those communities. These trends are also supported when you look at emergency room data around ICD-9 codes that suggest child abuse and neglect. It's also supported by hospital admission data around children in hospital admissions, and it's supported by a gatekeeper survey that we conducted in Durham in 2004 and 2007. By gatekeeper, what I mean are pediatricians, daycare workers, teachers, people who interface with children on a day-to-day basis. They've been interviewed twice now to see if that's improving as well, and the evidence is that that too is improving. There are two primary challenges with the work at Durham that we're continuing to address. One is the whole idea of attribution. That is, without a randomized control trial, and instead using comparison counties, there may be other factors that have led to these improved data in Durham. For instance, the economy may have been stronger in Durham than it may have been in the comparison community. There have been any variety of factors that may have affected that. The other challenge is, how do you take what has so far been kind of isolated interventions? How do you take those to scale and not lose effectiveness when you're providing the interventions? They've come up with a strategy for doing this. It's called Durham Connects. In Durham County, there are 4,000 births a year. And what they plan to do is to have a nurse, an RN, visit every one of those births by the time the child's 12 weeks of age. The nurse will make up to 3 visits and will assess the families using a specifically designed assessment tool for this initiative. The nurse then, if the family's at risk for certain issues, will then make sure that a referral is made to the appropriate services in the community. And by doing this, they plan to make this intervention universal, so that is not just targeted to high-risk families, but to all families, so that you do norm the service, if you will. And 2, they hope to achieve broader reach within Durham County by targeting all 4,000 births every year.